Hello, my name is Laura Van Althuis, and I'm a registered dietitian and clinical research coordinator at Duke University Hospital. Today's course is just one in a series of subjects brought to you by Channel 1 On Demand Nutrition Education. Today we are looking at resting energy expenditure, a cloudy crystal ball. Today our objectives will be to understand how resting energy expenditure is measured via indirect calorimetry. Next, we will describe the role of indirect calorimetry in an acute and ambulatory care setting. And finally, we will compare results from measured resting energy expenditure to predictive energy equations. Calorimetry is the measure of heat. Direct calorimetry measures body heat production, which requires a large insulated chamber or room. However, indirect calorimetry estimates energy expenditure from the measurement of gas exchange utilizing a metabolic cart. Thermodilution and doubly labeled water are two other methods that won't be covered in this presentation. The picture on the right shows all of the components that go into daily total energy expenditure. But we will first focus on what is highlighted in the yellow box, which can be measured by indirect calorimetry. Indirect calorimetry can be measured using a metabolic cart in three different ways. First, you can connect sampling lines and flow meters into a ventilator circuit. For spontaneously breathing patients, you can also use a mask with a turbine and attachment, or use a canopy, which is also called a hood with a large veil. No matter what test you use, you want to make sure that you have a closed circuit with no air leaks, as these will lead to inaccurate measurements. Tests take about 10 to 15 minutes in the room, and calibration can take up to 30 minutes depending on what type of metabolic cart you're using. Common contraindications to indirect calorimetry include ECMO, chest tubes with air leaks, and FiO2 or PEEP that's greater than 70% or 16% respectively on a ventilator circuit, and the necessary use of supplemental oxygen. So you might be asking how REE is calculated. Well, after measuring the volumes of inspired O2 and expired CO2, the modified Weir equation can be used to measure REE. Respiratory quotient, which speaks to substrate utilization, can also be calculated by dividing the volume of carbon dioxide by the volume of oxygen. And as you can see, an RQ close to 0.7 describes the utilization of fat substrates, while an RQ close to 1 speaks to carbohydrate utilization. This is an example of what you may see on the screen of a metabolic cart. On the left-hand side, we can see that data points represented by the colored dots are taken every 30 seconds. The VO2 and VCO2 are represented in the blue and red lines, as we learned previously, contribute to the REE, which is in the large box on the right-hand side. This patient has a measured resting energy expenditure of 1,938 calories per day. We can also see that the RQ represents that fat is likely the primary substrate being utilized by this patient. I've also circled below the variability of VO2 and VCO2. In short, the more jagged the lines in the graph are on the left-hand side, the greater these numbers will be. In our tests, we aim to get these numbers below 10%. Additionally, on this printout, you can see that the duration of the test was 11 minutes and 30 seconds, and the FiO2 as set by the ventilator was 40%. Proposed by Cuthbertson and et al., the ebb and early and late flow phases of critical illness depict a steep drop in REE during the first day of illness, followed by a climb to about 140% or 1.4 times REE. Late flow phases show a return to about 120% of RE during the weeks after injury. Overall, this graph shows that REE does not stay the same throughout hospitalization. Since REE changes throughout hospitalization, let's now think of what predictive equations we have to predict these changes. Some that I have listed here are the Mifflin-St. Jeor, Harris-Benedict, and weight-based equations such as 12 to 25 calories per kilogram. It's important to remember that these equations use static variables of height and weight. Although you can argue that weight might fluctuate throughout hospitalization, this is typically related to changes in fluid status and potential bed weight inaccuracies, especially in critical illness. The figure on the right depicts that the Harris-Benedict equation in the open circles vastly underestimate REE, as shown in the closed circles above. The Penn State equation, on the other hand, uses dynamic variables of minute ventilation and maximum body temperature, but this is only useful for patients on a ventilator and can't begin to capture the energy needs of patients in the late phases of critical illness who are trach collar trialing or off the vent permanently. REE is also unpredictable in many disease states. In the novel viruses such as the COVID-19 virus, we can see that progressive hypermetabolism in the graphs on the left and right-hand side as calorie needs continue to rise post-intubation. The straight red and green lines, however, in either graph depict a predictive energy equation that unfortunately doesn't change as critical illness progresses. If these were used throughout hospital length of stay, we might see significant underfeeding of these critically ill patients. In a randomized controlled trial by Heidegger et al., those fed enterally with supplemental parenteral nutrition to a measured calorie goal by indirect calorimetry had lower rates of hospital-acquired or nosocomial infections. We can see this depicted by the red line at the top of the graph, but alternatively, those fed with only enteral nutrition reached about 77% of their calorie goal and had a higher mean number of nosocomial infections. Now, in looking at a large cohort of over 1,000 ICU patients, Zussman et al. Found the lowest rates of mortality when feeding 70% of the measured resting energy expenditure. Alternatively, mortality rates increased when feeding greater than 100% of a patient's daily calorie needs. It's important to remember that appropriate feeding of 70% of REE can only be guaranteed when measuring versus predicting energy expenditure. Now, indirect calorimetry also supports a diverse acute care patient groups. It can support those who are mechanically ventilated or spontaneously breathing, and it can be helpful to better understand the needs of those with a hypermetabolic disease state or chronic disease process, those who have lost limbs, and patients who rely on controlled calorie delivery through enteral or parenteral nutrition can also really benefit from measured resting energy expenditure. Now, we can certainly utilize indirect calorimetry in the ambulatory care setting as well. Understanding one's resting energy expenditure may be most helpful for somebody receiving controlled calories through enteral or parenteral nutrition. But what's most important to acknowledge in this situation is the use of an activity factor, as this population is ambulating and potentially exercising. I have shown this in the box on the right-hand side that is now larger than it was when previously depicted. Resting energy expenditure, we need to remember, is, well, resting, and will underestimate the calories burned by someone completing activities of daily life. So in conclusion, IC is a non-invasive and quick means of measuring REE. Tests usually only take 10 to 15 minutes in room. Predictive energy equations are inaccurate and often not dynamic. We saw how measured resting energy expenditure changes throughout hospitalization and how predicted REE often stays the same. Accurate feeding of 70% of REE has shown reductions in 60-day mortality and nosocomial infections. IC can benefit both acute and ambulatory care patients. And remember, you can use this in ventilated and spontaneously breathing patients. Thank you very much for listening. I would invite you to watch for upcoming Channel 1 videos on nutrition and learn more from my esteemed colleagues. Have a great day.